But I want to introduce you now to Jim Benny, who is the project manager and basically built the hospital. And so he's going to, we're at the very end of this, so he's excited. So he's going to walk you through what the hospital will look like.
So, is this one working? Can you hear me? No. Now can you hear me? Yes. So, nice to be with you tonight. Again, my name is Jim Benny. I am a registered nurse. So, a registered nurse built a hospital. How's that? So, I've been on the project for 6 years. Prior to that, I was director of nursing at Mills Peninsula, which you maybe have heard of. It's down there in Burlingame. And prior to that, I came from Baylor University Medical Center. So, I've had a good career. Brought a lot of experience to what we wanted to have in our hospitals here in San Francisco. I also live in San Francisco. My kids go to school in San Francisco. I'm excited because this has been a long journey, and I've heard about, depending on who you talk to, it was 30 years, 12 years. It just depends on who you talk to, how long it's taken to build these hospitals. But we are 50 days away from this hospital opening. Now, with that said, I'm excited. At the same time, you're not the group that I'm trying to get ready to move into that hospital. Those people, they have a lot of work still going on. So we have this huge transition that's been being planned. We've been planning it with the city. We've been planning it amongst the hospitals. But in basically 1 year, we'll move 3 hospitals into 2 new hospitals with the same team of people at CPMC planning it. And, you know, everybody thinks, oh, moving the patients, that's really hard. No, that's actually the easy part because you do that in 1 day. It's all the other days spent getting the building ready for that 1 day to move people in. So what I wanted to do tonight is I wanted to show you basically pictures of the hospital, tell you about services that are going in. I want to tell you about some of the technologies we're putting into the hospital that you may not see at another hospital, that we're doing things a little differently. We really have focused on the patient experience, the physician experience, the staff experience. We live in a place that has a lot of technologies, and technologies can enhance the care we give. One of the biggest challenges we have is communication. So we spent a lot of time working on technology that would improve our communication. So we are all doing handoffs clearly on the care we're providing to our patients. So I want to share some of that today too. But I'll just do some numbers because the numbers are quite impressive. We're talking about a new hospital that's almost 1 million square feet. It's big. I can tell you, I put in about 14,000 steps a day walking around it. And if you look at me, I wasn't putting those steps in before. It is a huge building, and that is a big change for our staff because our staff are working around smaller units, and now their units are covering a lot of beds. But we've also decentralized the nursing stations out, so you don't have one nursing station that's caring for all the patients. We might have 4 or 5 nursing stations throughout a unit because the idea is to get our staff down across from their patients. And when we do that, also put the med rooms down there, the supply rooms down there, the equipment rooms. So you end up with a bigger structure, but we have a structure that has a better flow for our staff and for those that we're caring for. So almost 1 million square feet, 50 specialists going in. I gotta put my glasses on. 120 private adult rooms, 26 private pediatric rooms. Every room is private except 6 NICU. NICU being the neonatal intensive care units because we have patients that come in twins. So we put those little twins together so their parents can be with the twins in the room. And I'll show you some of those pictures about those rooms. But those are the only semi-private rooms we have. Every other room is private. And I don't know if you've used our facilities over at Pacific Campus or the Cal Campus, but they're tight. So we managed in an old building to put 2 beds in a small room. Now you're going to see 1 bed in a big room. 13 ORs, 2 cath rooms, 2 interventional radiology rooms, 2 electrophysiology rooms, 7 GI rooms, 1 hybrid OR. A hybrid OR is cool because you bring the imaging equipment into the OR, and the imaging equipment moves over, scans patient, moves back, and it's all in the OR. 3 CTs, 2 MRIs, 2 rad X-ray rooms, 2 X-ray fluoro rooms, 3 nuke med rooms, 36 ER rooms. There are more ER rooms at this new hospital than at PAC and Cal combined. Again, all private, not just with screens, but with doors that shut. A lot of privacy. That's the one thing about a new hospital. There's a lot of privacy, a lot of noise reduction. All good things. Again, I talked about we wanted the visitor experience to be better. We wanted the patient experience to be better. We wanted the clinical experience to be better. So we've added amenities that we don't have today, like conference rooms. In the hospital, we meet a lot. You have to meet. We have to meet a lot to talk about a lot of things. We don't have conference rooms, but not only are we going to have conference rooms for us, but we're going to have conference rooms where we can have patient educational training going on. Up on the care units, we have conference rooms. We have consult rooms, because although it's great that we have private rooms, there's some conversations we need to have with the loved ones away from the patient sometimes. So we have the ability to pull over to a consult room. So we just have, lounges, staff lounges, that have the refrigerators and the microwave, the coffee pots that we need also. But then we have family lounges, so I'm going to be showing those things to you. So just to give you an idea, let's see if I can work this. So, there we go. So here's the hospital. The hospital is the entire city block. So it is sidewalk to sidewalk, the entire city block. We have Franklin on this side, Post on this side, Van Ness on this side, Gary on this side. Up here on Franklin, that's the 3rd floor of the hospital. Down here on Van Ness, that's the 1st floor of the hospital. Funny thing about living in San Francisco is we have hills that do this. So here we are at the entering on 1st floor, but if I'm going to ED, I'm entering on the 3rd floor of the hospital. And to just make it a little more challenging and exciting is right through the middle, we put a driveway right through the middle of the hospital on the 2nd floor. And I'm going to show you all this. That's the layout of the hospital. We do have across the street the medical office building, where quite a few of our clinics and specialists will be. And then, of course, we have bus routes. And one thing we wanted to do is we wanted to have a secure campus. Unlike our current campuses, you can enter in many different doors. We've limited the doors where people can enter. We've locked the place down. We want it to be more secure, more safe. But with doing that, if we've locked the front door, we have put a button at the front door where you can call and someone can come down and let you in if we need to let you in, if you're not able to walk or get your way down to the one entrance that's open 24 hours, which is the emergency room. Emergency room entrance is open 24 hours. When you look at how the hospital is laid out, we have parking structures on P2, P3, they're all underground. And part of P1, the unique about this hospital is we have 4 streets that don't stop operations around the hospital. They're just constantly, cars are constantly flowing on those streets around the hospital. So when we discharge a patient from the hospital, when we discharge you to your car, we can't discharge you to the street. So we have designed inside the hospital a discharge lounge. So we will bring you down on an elevator to the discharge lounge where we have told your family member, whoever's picking you up, to be there. And then we put you in your car and you drive out of the building. So on rainy days, that's nice. You're never going to get wet. Then we have conference centers, all these things that say support. Those are the things, the support areas, the environmental services, the biomed, the engineering, pharmacy, lab, all the things that support the care that's being provided up by the nursing staff up on the floors. On the 2nd floor is our main lobby. I'll show you that. Dining, some admin spaces, conference rooms. The 3rd floor is primarily the emergency room and imaging, and I'll show you that. The 4th floor is what we call our integrated interventional services. That's where all the OR, cath lab, IR, electrophysiology, the GI, non-invasive cardiology, all the interventional services are on one floor sharing one waiting room, one lounge, and which is huge, as well as 32 post-anesthesia care units. That's what we call PACU. So when you wake up from something that we put you to sleep, the first place you wake up is in PACU. And then once you woke up, then we move you to secondary recovery or to pre-op, which we have 39 of those. So, and again, this is more than both Cal and PAC together today. We've got bigger. Fifth floor is our labor and delivery floor, as well as our neonatal intensive care unit. That's where we have our C-section ORs, as well as the antepartum unit. The antepartum unit is the unit where we're trying to get you to not have your baby yet. So you may be trying to have a baby, but we don't, it's not time yet. So we're taking care of you so you don't have your baby. Then we have the intensive care unit, respiratory cares on that, our pediatric intensive care unit, our pediatric med-surg unit. Postpartum is after you've had a baby down here on 5, we move you up to the 8th floor where you recover on the 8th floor, as well as we have a 40-bed nursery. Then we have 60 beds of acute med-surg, medical surgical care, and the 10th floor is also 60 beds of acute medical surgical. These floors up here have the fantastic views. And then on the top is executive administration. Now we had this concept for the hospital, and you'll see it once I start showing you pictures. The philosophy, the color scheme that we did, the color palette we chose was based on elements. So the lower 2 floors were based on soil and earth. The next 2 floors were based on the vegetation that came out of that soil. The next floor was based on water that you need for the plants. Okay, makes sense? So the women and children floors are a blue color scheme, then or a water theme. And then the upper adult floors were based on sun, because you need sun for those plants. So they're lighter colors. And then the administration floor was based on air, and we say that's because there's a lot of hot air up there. So this is the entry to the Van Ness Hospital. This is the corner of Van Ness and Gary. And you see there's a staircase here, and some of you are already saying that's just too many stairs. I agree, I've walked them many times, it's too many stairs. Right next to that we have elevators. These elevators are not the elevators that go up into the patient tower. These are the elevators that come out of the garage or take you from this first floor up to the second floor, which is our primary public space, okay? We have a separate set of elevators that then take you up into the patient tower. And again, that's part of our security thing. You know, we want to control where people are moving, because we have a lot of people in our care and we want them to be safe. After you come up these stairs here or come off the elevators here, we have this long public lobby where there's an information desk and security desk that's watching these 6 elevators that go up into the patient tower, as well as we have conference rooms here, and here is our cafeteria, which is the Chuck Williams Cafe, and some of you may know Chuck Williams of Williams-Sonoma has put his name on there. We have 2 admitting areas. We have an adult admitting, and you can see that light theme coming through there. And we have a birthing and children admitting area here, and you can see the water theme coming through there. This is the drive-through that goes to the building. So you enter the building via car off Gary Street, and we have a drop-off area to go in the building here. So I've shown you an entry on Van Ness on the first floor. I'm showing you an entry on the drive-through area on the second floor. You can see the information desk. You see the meeting areas down there. There is a door off Post Street. And I bring that up because just outside this door is our shuttle drop-off area. So our shuttle will drop off right at an entry. So you can walk off the shuttle into the hospital. And the door is on an accessible push-button door. This is the emergency room. So this is the entry that's 24 hours off of Franklin Street. And when you come in, we have a security desk immediately here. We have 2 more shuttle elevators that only go to the parking structure. And then we have an adult waiting area. And then over here we have a pediatric or children's waiting area. So we've separated our waiting areas. We have a nurse that will greet you right here. And the nurse is going to put first eyes and determine what level of care do we need to give you right now. Are you someone that needs to go back immediately into the emergency room? Are you someone who needs to go into the triage room right away, which are these rooms these 3 doors here, or are you going to be able to sit for just a minute while we prioritize some other things ahead of you? Make sense? This is the emergency room. So we see a nursing station here. We see care rooms here. Notice these are doors. These are slider doors. We can see in, okay? But again, you have privacy. We can shut it. You don't have to hear all the noise that's happening in the ED. And for your privacy, we have curtains that can be pulled too. This is a waiting room in the imaging department. So you have a receptionist and imaging. And then in all of our areas, we always have a children's play area. We do have child life specialists that work in the hospital. So they make sure that there's toys out for the kids, there's games out for the kids, there's video games for the kids. That was my mistake with my kids, is video games. Then if you, on the 4th floor, this is our interventional floor. So there's 6 elevators here. You get off the elevator, there's a check-in here. Notice this big, large space for waiting. Yeah. Although we're going to be so efficient, you're not waiting long, okay? Large area. And notice there's a lot of different seating areas. We also have these computers because, you know, sometimes you're waiting and there's other things to do. A lot of us have our cell phones and stuff. We do have cell phone coverage for AT&T. We will have for Verizon by the time we open, and T-Mobile's in the work. Because one of the things about our old hospitals is you go in with your cell phone and they don't work. But what we've done is we work with each one of these carriers to run their signal over our system. So there will be no place in the hospital, there'll be dead zones for cell phones. So Verizon needs to hurry up and get on board. AT&T works well right now. Then we have a pediatric waiting area. So this is, again, a place for the children to come to, make as much noise as you want because there's a sliding door here. And then the next room is a family room with TV. So again, lots of different options for lots of different age groups. This is another view of it. So this window over here is Gary Street. This is another view looking back at that desk over there. This is the post-anesthesia care unit. Again, we created an area for our pediatric patients where there's doors, so as you're waking up, you're not hearing a baby or a kid crying as they're waking up, as they're behind a door. And we have you behind cubicle curtains because it's very efficient for us to move around from bed to bed as you're waking up from your surgery or your procedure you've had. This is labor and delivery, and this is where all moms would present. Behind this wall is a triage area because moms show up to have babies and they don't always stay to have their babies. We sometimes send them home and say, come back later, you're not ready yet. So this is in front of triage. This is a garden, and I'm going to show you another picture of the garden. But this is an exterior garden, so these have seating and area. This is a public space. Anyone can come out to this. So you can go outdoors without ever leaving the hospital, but you're in a very secure place. And this is off a waiting area for labor and delivery. So this is where maybe friends and family are, and those that are not in the room. This is a labor and delivery hallway. These are the rooms, individual rooms. Notice that we've added some just art and color outside of every patient room. Labor and delivery room, mom is here, family's over here. All of our rooms have family zones, and we're encouraging families to be able to stay over. We will provide you sheets, we'll provide you blankets, we'll provide you pillows. You can sleep. All these things make into full sleeping, pull-out sleep areas. And then, again, we want to have families be involved, friends and significant others be involved in your care. It's healthy for you, it's good for them. Our past history is we say there's visiting hours, goodbye visiting hours are up, get out, okay? No, now we want to be able to have people stay 24/7, and we can do that because they're all private rooms. Semi-private was difficult to do. They're all private rooms. So mom's going to have a baby here. This is medical gases, suction, everything we need to have a delivery. This opens up. It becomes very clinical. Mom has a baby, baby goes over here, care team taking care of baby, care team taking care of mom, and then we start pulling everything away and making it very hotelish again, except now you have a baby in the room crying. This is our infant security system. So any of our children that come in, we put a tag on them because we want to know if anyone's trying to take them off the floor. Doors shut, elevators stop working. No one can take one of our kids out of the building. But we've also started doing it we're going to be doing it for adults as well, because we do have a patient population that gets confused. We start giving you meds and stuff, and it starts, and we kept you awake almost every day in ICU. So you're confused, you're trying to walk out of the building. We're also going to be putting on adults to keep them from walking out of the building or walking off the floor. Because again, you're in our care, we want to make sure all of our patients are safe. This is a neonatal intensive care. We used to have big rooms with 10 of these in every room. We barely had a space for a rocking chair. And what we wanted to do is make them all private rooms. Now you see a family can be in the room with the baby, so we can have a family experience. This is an intensive care, so we have booms. All the care is hanging off these booms that's around this bed. And instead of the bed being traditionally in this way, if you want to look out the window, we can move the booms and we can move the bed so you can look out the window. You're curious what's going on in the hallway, we can turn your bed and put the booms and equipment in the direction of the hallway. So it doesn't have to be the same. And we also give you control of the lights in the room. We have thermostats in the room so we can change the temperature in the room. The idea is to give our patients more control of their environment they're in, because this is your room while you're in the hospital. This is our pediatric floor. You can see this is a beach blanket theme and a fish theme. Pediatric room. This is a patient bathroom. One of the things I like in every patient bathroom, we put these pull down assist to get off the commode. We have all of our emergency call lights everywhere. This is the patient room and our head walls and our medical gases and our nurse call system. In every room we have our documentation because everything's electronic now, our electronic health record. When we have a code event where a patient has a cardiac event, we need to get people to the room quickly. We have the ability to push a button and the operator's announcing it overhead immediately. And it's going to these devices that are those Sarah devices that all the staff wear, their communication device, but it says code blue 5155 and just repeats it. But then all the caregivers know right then and there, no matter where we are on this big nursing unit, that we need help in this room. This is a nurse call. It's a little complicated. We have simpler ones. But the thing is about this nurse call, which we will orient you to when you come in the hospital, is again, you have control of your lights. But although this is the nurse button, this is for toilet, this is for pain med, and this is for water. So if you're able to tell us exactly what you need before pushing a button, we're able to respond immediately over our call device without going to the room, finding out what you need, going and getting it, and then coming back. There's a lot of wasted time on our nursing units today going back and forth. So it makes sense if we know ahead of time what your need is. Plus, a nurse doesn't need to respond to your water needs. A nurse aide can do that. But a nurse aide can't do your pain meds, so we skip the nurse aide and go directly to the nurse. These are those Vocera communication badges I talked about. And that's how they wear them. This is a pediatric intensive care, looks just like an adult intensive care. This is child life, and this is a space that children can go to and interact with other children. Now this is the adult unit. So this here is, you see the light coming through, the lighter colors. This is coming off the elevators. This is at a nursing station. We have all these collaboration areas where physicians and staff can pull away and share information that not everyone else is hearing, plus they're doing that quiet area themselves. This is a hallway, this is a patient room. Outside of every patient room, we have sitting zones for staff to document, but we have these windows so we can sit and look into the room when we need to, but the windows have these little sliders so we can close them for privacy on both sides, inside the room and outside the room. This is the patient room, and again, you see a care zone over here. You see the patient bed here. What you're also seeing is ceiling lift. We have a lot of injuries for our staff, because if you've done this for 30 years, you've probably pulled up thousands of patients in a bed. You've turned them, and although we'd like to wait for my peer to come help me, I've already been waiting 10 minutes and you have too. So I end up doing it without someone helping, and then I hurt myself. These ceiling lifts, one person can turn a patient by themselves, lift a patient up, put them on a gurney by themselves, lift a patient up, put them in a chair by themselves, put them in a wheelchair. It's comfortable. All of our staff have been training on this. We have 3,500 staff to train right now that we're doing right now. So it's comfortable for the patient, it's safe for our staff, and we can move you anywhere in the room. And then this is an example of a patient family room. Look at the views. I mean, there's just spectacular views, and this is a waiting area up on every care floor. And on some of our care floors, we have for families, because we've encouraged you to stay over. Now, I'm not encouraging going to Tommy's Joint, okay? But if you go to Tommy's Joint, which is very good, don't eat every meal there. We have a lot of food around us. If you've gone out to eat and you're staying over, you need a place to put some leftovers. So we have refrigerators for families to put their leftovers. We have microwaves to heat them up, and we have coffee pots. As well as you can go downstairs to the cafeteria and get coffee. This is that public garden. So drought-tolerant plants, but we do have a water recycling program. So rainwater does get collected and is used for watering the plants. Remember, that's a nurse telling you this. You are quite impressed, aren't you? What questions do you have?
Do people fill out cards with questions? Do you have anybody with a card? No cards? Nobody got a card? Yeah, so why don't we take a couple of mics? All right.
Yeah.
Right, questions?
Hello?
Okay.
Question here.
Simple question, on which level is the garden? The one you showed us.
The garden is on the 5th floor. It's on the 5th floor, which is the labor and delivery floor, the neonatal intensive care unit floor, but where it's located, it's not in a locked area, so anyone can come down and use that space on the 5th floor.
Facing which street?
It's on the Post Street side. It's more on Post Street, but again, if you notice, there was still care units or rooms around it, but it's on the Post Street side.
Thank you.
So I have a question about traffic. The ER is on Franklin, so there's an ambulance coming down from north on Gulf. How do you visualize it? Have to go all the way around the block?
So when the public is driving in, so I'm taking my son to the emergency room, which is not an unrealistic thing. So I bring my son in, I'm coming up Franklin, and I turn into the driveway on Franklin. When an ambulance is coming in, the ambulance is coming off Post Street. So we separate the ambulance from the public driving. But one thing we did is our signage that's around the entire block is pointing you to two things. It's pointing you to the emergency room, and it's pointing you to parking. So those are the two things. So no matter if you're coming down Post and you're trying to go to the emergency room, you drive down Post, take a ride on Van Ness, take a ride on Gary, and a ride on Franklin, and you're into the waiting room.
Right.
Does that make sense?
Yeah.
What will 2100 Webster Street be used for once this hospital goes in?
So 2100 Webster Street is our medical office building, and we don't own that building. So many of those doctors will remain there. Many doctors that are more specialty care, that your cardiologists, your oncologists, neurologists, many of them will move to the new medical office building, but 2100 Webster will remain.
What about the facility up on California Street?
The Children's Hospital, Cal?
No, I got a new hip there, and I ain't a children.
Okay, so the Cal campus is going away completely. So it will, that building over the next year will, those services will go to either the new hospital on Van Ness. If it's some services could go, if they're outpatient services, they could go to the Pacific campus. They could go to Davies or our new Mission Bernal campus. But the old Cal campus will be redeveloped for housing. And so we've gone through a very lengthy, many-year process with the community around there.
But specifically regarding orthopedics.
Oh,
Okay, question.
Regarding orthopedics, our physicians, they weren't too excited. A lot of them live on the other side of the bridge. They weren't too excited about going down to Mission Bernal, but we got a couple to go down there and start doing their orthopedic surgeries down at Mission Bernal. They love it. So Mission Bernal is the old St. Luke's on Cesar Chavez. So it's our brand new hospital that we just opened up August 25th. So we're going to probably start seeing a lot more orthopedics done there, but orthopedics also be done at Davies.
Question over here.
Yeah, hi. Thank you for the presentation. It's a beautiful facility. Congratulations.
Thank you.
So I'm from one of the local high-rise condo boards and on the neighborhood, the Cathedral Hill Neighbors Association. And we spend a lot of planning and money on lighting around our buildings in the past couple of years for our neighbors and for your customers to come by the hospital. So we're surprised that you don't have exterior wall sconces on your building. When you look at Geary or Post Street, they're dark. You're relying on street lights. How come you don't have more lighting other than at your exit doors along the street? It's not a very safe neighborhood in some ways.
Yeah, I'm not the right person to answer this, but I will say that's probably the first question that we've gotten about not enough lighting. So our hospitals are dictated by OSHPD, which is a state entity. So much of what we do, we have to go through the state as well as the city on lighting. So everything in the hospital had to be pre-approved. So I don't know if maybe Valcon can answer that question a little bit more about the external lighting, but that's the first that I've heard that we don't have enough.
We think you're going to regret that fairly quickly.
That's really interesting actually to hear. Was there any?
We've
hold on, please.
And from the standpoint of security, you might want to address security.
I'm Vahram Masegyan, but for the sake of ease, folks just call me V. I worked on the entitlement phase of the project. From a lighting perspective, most of the work that we are doing is focused on the facility itself. The lighting program is, and the building is built, from curb to curb essentially. We have no setbacks on any side of the building. The building is going to throw a little bit of light since it is a bit of a glass box. We're trying to minimize that to a certain degree because we understand we're living in a city and that also impacts residential neighbors, particularly Denver and Cork neighbors. But from a lighting element standpoint, we essentially build to our property lines and haven't put anything out on the street side other than on the Van Ness side where we've done some sidewalk widening to allow for more streetscape features.
But his point is we don't have enough
That we don't
light.
have enough.
Which is, again, the first time I've ever heard that.
Yeah.
Well,
because even our exterior signage, there was a great degree of concern regarding our signage that's lit. I'm starting to remember these things now. Is that there was a great deal of concern that the signage we had was too bright. So, but what we do have, because we, again, moving from Pacific Campus to our new neighborhood, there is concern. We did put security cameras, so we do have security cameras all around the building. But I hear what you're saying about light. Yeah, and we're just going to have to get in ourselves and experience it. What I'm saying about the inside too, we guys can move in and let's experience how things are before we start making changes.
To answer him, we're not talking about the property line. It's just low level, like 8 feet above the ground wall sconces.
Yeah,
Well, and we can, I thank you for that question, and I think as we get into that building, if more light is needed, then we can address that, absolutely.
Okay, question back here.
You mentioned 3,500 staff and parking. So when I was wondering, I know there's not going to be 3,500 working all the time, but what's the parking allotted for staff and for the public? And what are the entrance, the access points off of which streets?
Yeah, hi, good evening everyone. My name is Ray Cortado and I am the parking manager for CPMC. Our main goal is to keep traffic from coming into this neighborhood, meaning they are our employees. So we have set up two main campus garages. One will be at Japan Center where we have currently 400 permits there. And the second one is Clay Webster Garage at the Pacific campus. We're planning to have shuttle come and go from both locations to Post Street and drop off our employees. The point of entry for the garage here at Van Ness, the hospital itself, is from Post Street, and they can also come in from Gary. And the exit is only on Post Street.
So what's the quantity? What are the number of spaces in the building?
Inside the Van Ness garage?
Yeah.
No, that is correct. So we have a total of 800 spaces between Japan Center and Clay Webster Garage. We are only accommodating on-site VNC, our physicians, patients, and visitors only. Our employees will only be able to park there on weekends.
I have a complimentary question if it's okay for me to ask.
Sure.
The hospital
We
is...
missed the quantity too of the parking before you go on to the next one. What was the quantity in
She's
the...
asking how many parking spots at Van Ness Hospital.
At the Van Ness site, we have a total of 816 spaces.
You're talking about both MOB?
Both MOB and the hospital, correct.
How many just at the hospital?
The hospital has 433 spaces.
For the public or for the staff?
It is mostly for the public and physicians.
I have a question which has to do with traffic as well as parking. The hospital is located on Van Ness and Post and Geary and Franklin, which are four very highly trafficked streets. And you have been describing a hospital that has an extraordinary amount of employees, patients, flow, automobiles. How are you going to manage that without making the neighbors around here crazy?
That is a very good question. We did our analysis for the last year and a half or so, and where we came up with, again, 800 spaces available, and we can increase that number at Clay Webster Garage to additional spaces offering attendant parking. Here's where we have done to include our plan. And that is that we have offered our employees to take public transportation. We do have a subsidy if they take BART or Muni or other ways to get to work, for example, the ferry.
Can I add? Yeah. Son?
Hey, if Big Brother is watching us, where are the cameras?
Okay, can you hear me? Is this working?
No?
Yeah.
All right. So as part of the settlement agreement between the city and CPMC in 2013, there is a very detailed parking, transit, public subsidy program, patient parking program. It's in the documents that are posted on the website, the planning website for CPMC. We can go into it in detail, but there is no plan. There's going to be 2,200 employees at Van Ness campus. There is no plan for these employees to drive and park in our neighborhood. That is not going to happen. There's going to be every other diversion, and it's heavily funded, and it is going to be enforced by the MTA, and the employer will be fined. They'll have to pay fines, so that's not going to happen. The garages are for patients, emergency responders, and physicians, and family members. It's not intended to be a parking magnet for employees and to shut down the Van Ness corridor. So we can talk more about that. It's a very detailed agreement, but traffic is a major issue and was a big part of the negotiations. All.
So I have a question specifically on...
Excuse me. Have you made any arrangements with Muni for increased bus service to the area. You're surely going to need it.
Hi, V again. So yeah, we have working relationships with the MTA and the city agencies. I think we had high hopes for the Van Ness BRT being opened when we opened, but I think that the ridership and the number of buses that are going to be serving this pretty transit-rich intersection at Van Ness and Geary are only going to improve with the Van Ness BRT project, and then the Geary Rapid Bus project. That's I believe almost that's for our stretch is completed.
Almost, yeah.
Yeah. So I think I mean, based off of how once we're operational and we actually see what the impacts are. I mean, everything's been analyzed to death through environmental review, but you know, once we're operational and things are flowing, we'll be working with the city to advocate or you know, try and promote certain elements of their transit first policy.
So following up on the parking, as someone who lives in reasonable proximity to the Pacific site, there's been an ongoing problem in the neighborhood with staff parking on city streets, and every 2 hours they go out, or every 2 hours or so, they go out and they shift cars. How are you monitoring if that's starting to happen at the new hospital, the new site? And if you see it happening, what are your contingency plans to manage that?
Well, as part of our transportation demand management plan, we have annual survey requirements that we need to survey our employees and submit those surveys to the city. And a number of the questions are going to be about how they park, how they get to work, how they take transit. So we take those results and analyze those. We also have a triennial requirement for patient visitor parking. So it's essentially going to be, a lot of it will be survey-based analysis, and then also, since we're moving into a neighborhood that has very little on-street parking, it's going to make our employees it's going to be a lot harder for them, for the Van Ness and Geary campus in particular. And we're hoping that the beefed up shuttle program that we're going to be providing, that'll be running our staff from PAC to Van Ness and Geary will help keep some of our parkers, or some of our employees come from very far away to work. Some of them work here in the city, but we're trying to balance and create an environment that supports our employees but also respects the neighborhood. And it's going to be, it's a fine line, and we'll be tweaking it as we're operational.
Question here.
I'd like to continue on this. I represent one of the high-rises very near, and this is a quality of life issue. I think candidly, when you bring a facility of your size into this neighborhood, it will tighten things up very definitely. And so a person making a right-hand turn into the hospital at Franklin slows down that lane, or perhaps shuts it down. I guess very candidly, we are going to be squeezed. And so I'd like to acknowledge that and know that there will be some adjustments that will have to be made. You don't bring a facility of this size in and not have an impact. The other thing is, we also sleep in the neighborhood, and there will be emergency vehicles, and I imagine we will have an increase in the sirens, and so that also will affect quality of life in a very significant manner. And would you agree?
I'll take off. I think you're absolutely right. We're going to have to tweak this. We are coming into the neighborhood, and there are going to be things that we're going to need to fix. In regards to emergency vehicles, those have nothing to do. We have no say in when the ambulance driver turns on or off the siren. Basically there are rules. That's all done through the San Francisco Fire Department. So I think that's something else that we're going to have to work with SF Fire Department on. But there are rules in regards to when the sirens can be turned off, etc. But that's all through SF Fire, not us.
Right. But again, realistically, there will be sirens that we haven't.
I don't know, I want to say, and don't quote me, but I want to say it has to do with the proximity from the door and if they've got the line of sight. Is that right? That they turn off the sirens. But
500 feet.
500 feet.
Oh,
500 feet.
so rule of that?
I'm sorry to ask you to repeat this question, this inquiry, but you're starting the move into the hospital March 8th. Over what
March
period?
2nd. March 2nd.
March 2nd. Over what period of time do you anticipate you will take to complete the move in of all your patients and to have it up and running fully?
So on March 2nd, we'll move the Pacific campus. So starting at 8 in the morning, we will start moving the first 2 patients. We have 2 teams, a red team and a blue team, and we have the ambulances all lined up, but we start moving the patients. ICU patients will move every 6 minutes. The med-surg patients, the acute care patients will move every 6 minutes. And we will plan to move 158 patients on Saturday. We'll start at 8 in the morning and we're done by 6 p.m. On Saturday morning or Sunday morning, we come back and we do it all again for the Cal campus, starting at 8 o'clock in the morning. We only have about 58 patients, I think, we're expecting to move on that Sunday. So we anticipate some of our sicker patients are the NICU patients, and we plan to have 35 of those. But we plan on moving those again, same situation, every 10 or every 6, and we plan to be done by 3 in the afternoon. So we'll start at 8 and finish at 3 on Sunday.
Thank you.
You're welcome.
Question over here.
Thank you. We're part of the neighborhood too, I represent a church, and there's at least 5 churches, maybe more, just in the Cathedral Home district. And Sunday is the day that I understand that it's sort of the day that people could park in your parking lot, your employees. And I think that will impact, because the community doesn't run as often on Sundays and BART and so forth, there is going to be an impact on our streets on Sunday, and so we're concerned about our parishioners who come and expect to be able to park near their churches. So if we notice that things are going on, first, who do we contact? And second, what kinds of sort of deals can we make about parishioners riding your shuttle or other things?
Sure. So we've spoken to many of the churches already and talked about parking. Rigo Hurtado runs all the parking, and so if there are things that are just, you're saying, we got to tweak this, we're happy to work with you.
Thank you.
I had one question regarding the move-in and also after the move-in. Traffic's going to be probably bumper to bumper for a while as people get their bearings as to which way to go and making right turns, left turns. I'm concerned because this community, as you can see here, is a lot of seniors. And I am afraid to cross that Gulf Street, with all the cars turning and everything. Could we request to have a couple of traffic, guards or something to help the seniors to cross safely? Because I think that there's going to be a lot of confusion for a while. And I know that, cars as it is today with pedestrian accidents and things like that, I just don't want to see that increase.
That's a great point, and I think that we continue. We meet with the mayor's office and with city agencies and with members of the board of supervisors on a pretty regular basis. And I think like I said, once we're operational and we see how things are flowing and how we're performing, it's going to be a dynamic situation where we will be adapting. It's a city, so it's constant adaptation that we're probably going to be engaged in. But that sort of feedback is good to hear. That that's a concern, and that's a thing that we can work with our partners at the MTA.
I have a question, but it does not concern traffic. I would very much like to know what advances in technology and equipment the hospital will have.
So we have a lot of new equipment that's going in the building, from new imaging equipment. It's all the newest stuff, from cardiac monitoring equipment, all the newest stuff. We've been, one thing about when you purchase millions and millions of dollars of this stuff, hold on to it a long time. And if any of you know, as soon as you got your new phone, it's out of date tomorrow. So technology and our new equipment's been like that. So right now we are getting all the newest of equipment that's coming in. But some of the things that you may not be excited about, but I am, is in the ICU we have these bedpan washers. Okay? I know that's not what you're excited about, okay? But me being a nurse, and I'm just going to be a nurse, okay, for a minute, is a lot of people say I put up with crap. As a nurse, I get to clean it up. Okay, so it's just the nature of our business, right? So whatever comes in, comes out. So in the old days, we'd have to carry it down the hall. Well, this is 2020, okay? We don't need to carry it down the hall anymore because I have this neat little dishwasher now in my room that I can put any type of bucket in there, contents and all, push a button, and I have a clean bedpan, a clean urinal, a clean fracture pan. That kind of stuff, although it's not high-tech, it's adding to the experience, okay? And it's better care, okay? I know, first time you see it, you're going to be amazed too, I know. But our beds, we just got these new beds. Hillrom just put them out for the med-surg patient population, the patient, basically acute care patient. And the ICUs, we got these striker beds. Now these, I know as a nurse, I could tell you to lay down. Now I've told you already that 20 times in the last 2 minutes. Lay down, it's okay, lay down. By the end of the shift, I've said that 1,000 times. I now can set the bed to tell you to lay down as you start coming out of bed. And I can not only tell you that in English, but I can give you into 40 other languages. I mean, you laugh, but it's real. It's the real stuff we do as clinicians. I'm a nurse. I mean, it's the real stuff we do. So it's some of those technologies that we are able to purchase right now that just make our jobs easier, but it's a better experience for the patient. Because the bed's not going to get frustrated saying it 1,000 times.
Are the beds bigger?
The beds are, I don't know if they're bigger, but the mattresses, you know, again, when you're laying in bed and you're laying on bony prominences, at that point you start having pressure sores, okay? So our beds are low pressure reducing beds. So as you move in them, they're automatically adjusting the pressure to your bony prominences. So they're top-notch beds. They have a lot of safety features in. As I go down the room, if I look over and I see any dots illuminated on the floors, that means the bed's not either in the lowest position, because I want it in the lowest position in case you do get out. The side rails are up and the brake is on. Those are just little things that are important for us, because when you go to get out of bed, we don't want the bed moving, right? So we want the brake on. So as I'm walking down the hall looking at my patients in my rooms, if I ever see anything illuminated on the wall, I know the bed's not in the position I want it to be. But I also need to know when you're getting out of bed, if I've asked you not to get out of bed. So as you start to exit the bed, I start getting alarms on my badge, my Vocera badge, to say you're exiting the bed. It's also going to the nurse call. So we built in some of those safety features using some of this technology that is available. It just hadn't been integrated into medical equipment.
Good evening. With all this technology, has all the equipment been tested for radio frequency interference? I know we use wireless mics at our church, and I'm sure all the churches do. Yeah. And that's a big problem.
So FDA oversees that, Federal Drug Administration oversees that. So there's only certain frequencies that medical equipment can function in. So whatever you're using at the church across the street, it's not going to affect us. It's also the cell phones. Remember in the old days we kept saying turn off your cell phone, turn off your cell phone. We still don't know why we have to turn them off on planes. But turn off your cell phone, you're in this cardiac unit. They don't function on the same wavelengths.
And I was also concerned about the broadband effect of high-tech equipment that puts out a signal that's wide.
It's not going out beyond our boundaries, so that's not a concern.
Good evening.
Yeah.
So quick question. One is going to be for V, is it V? Yes. For parking. So have you guys reached out for the CPMC staff? Have you reached out to the Chinese consulate? One, because we have issues. I represent the Archdiocese. I'm Director of Security and Safety. So as everyone knows, we have an open parking lot. So we already know and can imagine the issues that we're gonna have with, you know, hospital traffic, because we have the consulate traffic and everybody else in the city. So I know you guys talked to John Christian, one of our other persons. Him and I met this evening, and we didn't talk. It just dawned on me. We actually have some potential solutions for night for your staff to maybe park, but I'll have to get with your security team to kind of talk about the logistics of that. But I think we'll be willing to kind of open that up to take some of the stress off the streets. But the other thing is, like I said, I know you guys talked to John. We know for right now, because we don't have barriers, arms, and all that to secure our parking lot, we already know we're going to get probably the bulk of your visitors coming over to park. We don't want to tow people, but as you know, we will tow people. And, you know, times is tough right now, so we really don't want to tow people, but at the same time, I think it's really worth us to really dissect this concern.
Yeah, Jacqueline and Rigo and I met with the Archdiocese, with a colleague of yours, and we did talk about also St.
And we also met with St. Mary's as well in regards to parking there.
And I think there was a gentleman here from Hamilton Baptist as well that we'll be reaching out to. But Chinese consulate, we haven't had any contact with them. But if you know, we're going to be a part of the neighborhood. So if you want to talk afterwards about it, if you have a contact person over there, we can work with. We also were talking about maybe some signage that are trying to dissuade some of our visitors from using parking facilities that aren't you know, for the churches or for the school. I know Sacred Heart also uses your park for some of the kids there. So I think.
But really quickly.
Too. Unfortunately, if they don't pay, they don't have a account.
No, and we're happy to work with you actually, because we could give you some signage as well, and we should have a proof of that tomorrow. So if you want to put that up, I know we're going to work with St. Mary's with the cathedral on that as well. Exactly saying that this is not hospital parking and you will be towed.
We're not concerned about our office parking, because if you come in and you piggyback,
yeah,
you're not going to be able to get out.
Yeah. So then for So for the cathedral, we are giving the signs.
Right.
Yeah, but absolutely, it's a work in progress, and we'd love to work with you more.
Do you charge for parking in your building?
Yes.
Yes, yeah.
Yes.
Good evening, hello. I have two intertwined questions, somewhat selfish questions. I manage the Buchanan Hotel at Buchanan and Sutter Streets, and we were working under the assumption that this was a 2020 launch. And so with this being CPMC 2020, I just am wondering if you could speak a little bit more to whether this is a multi-phase timeline or whether it's a full go live, and then most importantly, how we can reach out to the administration of CPMC and make sure that we are the hotel of choice.
Okay, so we can absolutely work on that one. That's great. 2020 just had to do with the state legislation where the hospital had to be rebuilt. Our date has always been this date. So this new hospital will open March 2nd. The emergency room opens March 2nd. So we are ready to go.
On move-in day, on Sunday, were those ambulances every 6 minutes? Will they have their sirens on?
No. So it's a controlled move. It's a fine. And who just asked the question? I'm sorry. Oh, thank you. I'm sorry. I keep looking. Thank you. So it's a controlled move, and because it's not a normal day, because we'll fed people breakfast, we'll met with the families, we'll met with the patients, we'll provide all this information days leading up to the move, so you understand this is how the move's going to go, this is what you can expect, this is where we want families to park, you know, here's where you can wait. You know, we're putting out all this information, but we want to do it in a very calm way. So it is not, we do not want the ambulances going down the road, sirens blazing, because that's not good for the patients who are just trying to get you moved. This should be no different from pushing them down the hall in the hospital, putting them on the ambulance, driving down to the new place. The only time we'll use an ambulance, and it's going to be sirens, is going to be on very few patients, is we have sick patients. And those sick patients are going to move. But we want to get them there maybe a little faster, not stop at all the stop signs or all the stop lights. And it would be most likely the police escort. And we were just talking about this today. So those would be, and it's a very limited number of those patients that would be coming under a siren.
Hello, I had a question. Oh, is somebody else? Oh, I had a question. Hi, I'm right here. So I wanted to know from the nonprofit standpoint, will you guys be opening up or providing any opportunity or grant funding resources to nonprofits that are here in the community to serve those in Western Addition? And also, like, would you guys be having any like mobile services maybe? So coming to families that really can't get to you guys, will you guys have any opportunities like that?
So we have, obviously to build the hospital, we've worked with many of the folks all throughout San Francisco in regards to community benefits. I don't know exactly what your specific question is, but we have robust community benefit programs throughout the Bay Area and throughout San Francisco, including Western Addition.
So will you guys specifically from your site be doing any mobile services? Like for example, if there's a family that lives in Western Addition, or if there's a nonprofit, like I work at elementary school, would you guys be able to bring a bus or bring some of your supports to our school to service our families?
So we don't have any mobile units that we could do that, but we frequently will do we do health fairs, we will go to schools and things like that. That's something we've been doing for years.
Just for CPMC in general?
What's a Sutter Health?
Sutter Health? Okay.
Yeah. Okay. Yeah, absolutely. But if you have something specific that you need,
yeah, because you guys are in the community, it's like, well, hey, let's go to, because I'm at an elementary school, so it's like, let's go visit that actual hospital, and that might be something that you guys can do for the community and give back, and also grant funding opportunities. So like for a lot of the nonprofits or the churches, how will we be collaborating exactly with you all?
So yeah, absolutely. I'm the person you want to talk to. My colleague Emily Webb handles community benefits.
Okay, yes.
We do a ton of grant funding and work with most nonprofits in San Francisco already. And then I love your school idea. We're already, we work at Galileo, so we have a program with Galileo where their students intern at PAC, but they'll be coming to the new hospital. So we love any new ideas that you have.
Actually, next week I do have the Galileo Academy of their Academy of Science program, the resident program. Yes. They're coming, and I'm escorting them through the new hospital next week, as well as Sacred Heart. So I have both coming next week. So we do have partnerships with schools.
Okay, elementary want to come too.
And I can also speak to some of the local hiring provisions that we have entered into with the city. We have a local hiring provision where we target to try and hire our entry-level workforce, about 40% from the city. So that's for both clinical and non-clinical positions. And there's a program within the city called First Source Hiring. It's a referral system. So we've been working with them, and our numbers since the start of the development agreement have been over 40%. But if you've got maybe just beyond elementary school, but high school and folks who are working in trades, we have a program, and we can talk about that as well. And we're also we're members of the Lower Polk Community Benefit District, and we've funded some programs in the Tenderloin in particular, since those are areas of need, and we have partners along the Polk Street and Tenderloin side of the campus. But this is a good opportunity for us to also reach out to Western Addition and others.
We have any more questions?
Thank you. How much did the building cost, all told?
Including community benefits.
All included, including community benefits, $2.1 billion.
Wow.
So it's no small asset. When you look at just the hospital itself, that's like it's like we're spending basically 1.7 million per bed.
Yeah.
Hospitals are not cheap to build.
And a linked question, at any given time, you have 274 beds, you said. At any given time, what will be the patient population in the hotel, in the hospital?
It's going to feel like a hotel, except we do stick you every once in a while. So we're going to run pretty full from day one. The city did it was originally supposed to be 555 beds, if some of y'all remember, and we're going to be 274. 274 is really more, it is less than what we have today at Pack and Cal. So a lot of our patients, and we've already been seeing it, are already starting to go down to Cesar Chavez, our Mission Bernal campus, as well as our Davies campus. But we're going to pretty much start on day one with 274 beds preoccupied. And we've been working in strategies and looking at our strategies and looking at our patient volumes and looking at our physician practices and been strategizing how best to move our patients throughout the city.
If you anticipate high occupancy, how do you anticipate the ER working? I mean, how long would people have to stay in the ER to get a bed?
So we've been looking at a couple of strategies with ED. You're really stretching my clinical here, okay? Because I am the senior project manager of the hospital. So we have been looking at some strategies of how to move our patients along, move patients through. Discharge lounge is one example. You're ready to go. We need a bed. Someone's waiting. Is we do have our discharge lounge. So that's one. The other is we're looking at how to create. Some of our patients are there for observation. They're never admitted to a bed, but you need longer time to evaluate what are the lab results, what did the tests come back. We're not quite sure if you're ready to go home or are we going to find something where you need to be admitted. We have quite a few observation patients, so we are looking at an area in the pre-op, post-op area. Again, they're all private rooms. Instead of having gurneys in there, we're going to put beds in there, and we're going to have a dedicated observation unit, which would take a strain off some of the inpatient beds. That was a good question.
If you have a full house and you have to divert patients to other facilities from an emergency room, where will they go? To other CPMC hospitals?
So we don't handle the diversion project. That if a hospital goes to divert, only if there's an emergency, we very rarely will go on divert. That's really done in collaboration with the San Francisco Fire Department, with EMT. So we won't just, if we've got, we don't go on divert as much as like San Francisco General.
But it does happen.
It does, and I would assume if we were to randomly go on divert, if there was some power issue or something happened, then you would probably go to, if it was non-traumatic, then I think you would probably go to St. Francis or UC.
Thank you.
Yeah.
This is just a question about joining the community. Do you have volunteer opportunities at the hospital? And if you do, the neighborhood has a number of people who are retired. How would folks learn about those opportunities? Do we have a place where we can coordinate that through maybe the neighborhood association or something? But
absolutely. So I will get that information to Marlene
right.
and folks here and give you all that. We would love to have you all as volunteers.
Okay. Yeah, and you have no helipad.
No helipad.
No helipad. Okay, thank you.
We do rely heavily on our volunteers, and we do have a very robust volunteer program. Just to give you an example of how much we're drawing on them for the patient move, we will have 250 volunteers on the patient move day.
Wow. Oh, yes, sorry.
Could you talk a little bit about backup generators?
So we do have backup generators. We have 3 backup generators. It's enough power to light up 70,000 homes, which is pretty impressive. The thing is, we don't need 3. The government requires us. OSPOD, a state organization that oversees hospital buildings, requires it. It requires 3 because it assumes that at any given time, every electrical outlet in the entire place is being used. Well, you and I know in our homes, we're not using every outlet at the same time. But in case we ever did, we had 3 generators. So the only time generators are used is if we come off PG&E. So again, these hospitals, this hospital, our Mission Bernal Hospital, Mission Bay Hospital, all these hospitals were being rebuilt because we live in an earthquake zone. So not only do we need to withstand an earthquake and still be standing, we need to be fully functional. So we have generators because we need to generate our own power. So we become our own little cities. We have our own emergency water source. So we have a 50,000 gallon water tank. We And again, the whole idea, whatever goes in comes out. We have a 50,000 gallon sewer tank because the assumption is if we're not on PG&E, we're not on city water, we're not on city sewage either. So again, and we have our own emergency food system, our own emergency food in the hospital. So again, we become a fully independent city within the city.
And those utilities are all right there
They're all within the building, right? And the generators are on top of the building.
Jack.
Will there be a house staff and a relationship with either Cal or Stanford medical schools?
So we do have a relationship with Stanford. We've had one for many years. It's the pediatric specialty care is done through Stanford.
But we do have our own residency.
And we have our own residency programs as well. Through DARTS.
How often will you guys emergency generators be tested?
Mike.
So the requirement, remember I'm a registered nurse, okay, let me preface that. But we do have requirements through Joint Commission, through CDPH of regular testing of the generators, because they can't sit idle. But I believe it's a monthly test. And during that monthly test, we switch to generator, and then we come back off the generator. So you have to run it so many minutes, so many hours.
That's what I was going to ask. What your chief engineer? How long will all 3 generators run consecutively?
I couldn't tell you. I'm sorry. But I'm a nurse manager. I can make something up.
We can get back to you on that one. We're not the right people to answer that question.
I can just speak to our chief. You can think of these hospitals as almost like an aircraft carrier or a large naval vessel. They are cities in of themselves. Our backup generators and our emergency generators are also highly regulated. We went through very rigorous requirements through Bay Area Air Quality Management District to make sure that these systems are state of the art. But they, monthly checks. But we would have to get back to you on the cycles.
I have 2 questions. One is, they're not related. One is, what are the expectations with regard to the capacity of the hospital? It was built for over 500 patients. And at some point, no?
No. So the original design was to be a 505-bed hospital. With the city negotiations, it came down to a 274-bed hospital.
I thought there were provisions for possible expansion.
We did. That's correct. So we do have some shelved areas but the most we could possibly grow to is about 350. All the emergency functions, all the storage functions, all the supply functions, all the support areas can support up to the 350.
Second question relates to, is there a helicopter landing pad?
No, there is not a helicopter landing.
Thank you.
Question for you.
Just to follow up on that, I will say that our new Mission Bernal campus, which is only I think 1.7 miles away, or it's extremely close, has 120 beds there, and that's a part of the CPMC Sutter healthcare network. It's a brand new facility, state of the art as well. So these 2 facilities are minutes apart, depending on traffic, but it is an integrated system.
So how strong an earthquake can you withstand?
So they can withstand an 8.0 earthquake directly underneath us. So the technology is they're viscous wall dampers. What they are is they're these metal encased. It's gel encased. The metal exterior with this jelly material on the interior. It attached the floor above, the floor below. As the building goes to shake and the earthquake tries to move the building, there's this tendency for the building to do this. That jelly material and these 190 viscous wall dampers take that seismic energy and suck it into the jelly material so it barely moves. It's technology that's been in place in Japan for 20 years. We're the first building in the United States to have it. And we can all agree Japan has earthquakes.
Thank you so much to our fabulous presenters. Can we give them a round of applause?
Thank you so much. Very quickly, what I would love to do is have these folks introduce themselves so you can have a name with a face and you can know what everyone's doing. So,
hi, Jacqueline Lesage, Government and Community Relations for Sutter Health for San Francisco and East Bay. I've been working for the hospital for a little over 3 years, so I may have met some of you here or there. Also, you all have received a flyer on your chair. On Saturday, February 2nd, we're having a big community day. It's basically an open house for the community to come see the hospital. We'll have activities, food, tours of the hospital. So if you are available and would like to attend, we really encourage the entire community to come out and see. Saturday, February 2nd, there's flyers around, and I left more on the table outside. Anyone next?
Hello again, I'm Rigo Hurtado. We've been with CPMC, I started Presbyterian, and I've been there for 41 years. And I know everything about parking, and I hope to learn more. Thank you.
Hi, my name is Adrian Gutierrez. I'm the security manager for the new hospital. I've been with Sutter for about 11 years, and before that I was a police officer for UCSF for 6 years.
My name is Tamika Greenwood, and I am Government and Community Relations Manager for Sutter Health for the East Bay of San Francisco, and I've been here about 5 months.
Hi, my name is Drew Richardson. I am the Director of Patient Transportation and Logistics. I oversee the patient transportation staff and our shuttle service that goes between our campuses. I've been with CPMC for about 10 months now.
My name is Austin McCamey. I'm the security manager for all CPMC. I've been at CPMC for about 3 or 4 months now. Prior to this, I was with John Muir, who's our security director, as well as Alameda Health.
Melissa White, I've been with Sutter for 3 years, 4th generation San Franciscan. So.
Yeah, like I said, I'm V. Lived in the city 10 years. I'm a Mission Bernal guy, so I live on the east side of town, but I'm a project manager for long-range planning and compliance with our agreement with the city.
I'm Arlene Morgan again from Cathedral Neighbors, and I think Alice and Sandy's still here from the Japantown Task Force?
Oh, she's right.
Okay, so I think I know pretty much everybody in the room, and if you're from Sequoias, I have a way to contact you. Carlisle, a way to contact you. Unitarians, Baptists, Catholics, 66 Cleary, Daniel Burnham Court, Post International. If there's anybody that I don't have your email address, please give it to me before you leave. We want to get you on an email list. There's going to be a lot of things happening in Cathedral Hill and Japantown over the next few years. There's going to be a lot of new building, there's going to be a lot of new transportation, there's going to be a lot of new impacts. We want to be able to have a voice in determining how this works out for our neighborhood for the best of our residents, so don't leave without giving me your information. Okay, thank you so much.
Would you want to give us your email address?
Yeah, I will. Everything I send it out has it on it. I'll send it out again. And it's posted in the Sequoias in the lobby.
Oh, good.
So, yeah. So anyway, this has been the first big project for Cathedral Hill, was working with Sutter Health to build the new hospitals in San Francisco. Second big project, working with 1481 Post, trying to have a community alternative for that. Other projects all over the Van Ness corridor, all over Geary Boulevard and Cathedral Hill, and we're going to keep working, and because things are not going to stop changing. So keep checking in. Thank you so much.